A very good morning to everyone. I'll be talking about the basic principles of managing a polytrauma patient. So, managing a trauma patient is a time critical emergency, and also it is very important because trauma victims are usually young patients. Trauma is the commonest cause of death in children and young adults less than 45 years of age group, and hence prompt diagnosis of injuries and appropriate resuscitation is important. Hence came the concept of golden hour, which states that the initial few hours, especially the first hour after the patient sustains an injury, that is a major injury or polytrauma, that hour is very important so that we, at this point of time, we can prevent major injuries if we can resuscitate the patient and manage the patient and provide care in the right time. With this came the concept of advanced trauma life support program. So what happens here is with this we learn to manage the patient in an algorithmic protocolized manner so that each and every aspect of managing these patients is taken care of in a protocolized, memorized way. You don't waste time thinking, and important life saving measures are taken care of. So it begins with a primary survey. So primary survey basically involves the initial assessment using the ABCDE algorithm. In this, we identify the injuries and manage them simultaneously. But before starting managing the patients, what happens usually that the emergency doctors are waiting in the resus bay, and often we get a call from the EMT, from the ambulance, and such patient has sustained trauma. They inform us the injury mechanisms. They might have been trained and they will record the parameters, and they may even have taken certain life-saving immediate measures at the scene. Sometimes they might have intubated at the scene, it may have been necessary. So you will get necessary information, and whether or not you get information or not, before the patient arrives, it is important to be prepared. That is, you notify the trauma team. The team will be ready before the patient arrives if there is time that you have received the notification. And otherwise, always keep equipments ready. Always keep things ready which are necessary for urgent resuscitation of the patient. Keep the airway trolley ready, the IV trolley to secure IV and quickly administer the fluids. You may have to keep drugs for immediate intubation and stabilization of the patient, vasopressors to support the patient. You may have to be ready to ask for blood products, collect the blood samples. So this all goes in the preparation. And once the patient arrives, you receive the patient. So you start with the primary survey. You can remember this as the ABCDE approach. So A stands for airway maintenance with cervical spine control. B is taking care of the breathing and the ventilation. C stands for assessing the circulatory status and achieving hemorrhage control. D stands for assessment of the neurological status, that is disability, and E is for exposure and temperature control. So to start with A, that is airway and cervical spine stabilization. Quickly, how in 10 seconds can you determine that the patient's airway is not jeopardized? If the patient is awake, simply ask him what's his name and what has happened. Suppose if he can answer this, it gives you an idea that his airway is patent for the timing, his breathing is not threatened, circulation, blood pressure is maintained, perfusion is there, that's why he's able to talk to you. And also at this point of time, his brain has not suffering in a major way. That's why he's able to understand and reply to you. So that's a quick, simple way to assess the airway. And so with regards to spine injuries, always remember patients with polytrauma or patients with injuries above the clavicle, head injuries, assumed that they have a cervical spine injury unless proved otherwise. So secure the cervical spine, put the cervical collar If it has not been done at the scene or in the ambulance, secure by putting a cervical collar and examine. All these steps should go on simultaneously. Simultaneously, look for signs of airway threatened airway. That is, are there any signs of airway obstruction? It could be partial, presenting as gurgling sounds, stridor, there could be hoarseness. The airway could be obstructed because of foreign body, that is, it could be blood, vomitus, or it could be threatened because of direct injuries to the face or the neck. Examine what is the tracheal position, see whether there is breathing. You may use the volar aspect of your forehand to see whether there is air movement. Once you have assessed the airway, and you may then need to use adjuncts. You may need to use certain equipments to maintain the airway patency. You may need to use a nasopharyngeal airway or an oropharyngeal airway. Always remember, in a patient with mid-face fractures, don't use a nasal airway. Go for an oral airway if needed, if the patient is able to tolerate. If the patient is not maintaining the airway and oxygenation, ventilation is jeopardized, you may need to have a definite airway. You may need to intubate the patient. So for intubating the patient, at the time that you're assessing, look for any signs of difficult intubation. So this is an easy mnemonic, the Lemon mnemonic, that is, look externally, assess, and look for any obstruction, neck mobilities, determine whether the patient has difficult airway. Whether or not, always keep these equipment standby. These are the minimum equipment that you should have as standby when managing a polytrauma patient, and always in the emergency area in the ICU, you should have these, because you may never know which airway may turn out to be a difficult airway. So you should always have a laryngeal mask airway, a plus minus intubating LMA, laryngeal tube airway. Always have a bougie. And in case your methods to definitely secure the airway fails, you may need to rush with the surgical airway. That is, you may need to go ahead and do a surgical cricothyroidotomy or a surgical tracheostomy. So it is very, very important for a polytrauma patient to always keep in hand an equipment for surgical cricothyroidotomy, because it may be very difficult. Sometimes patients with facial and neck injuries, it may be impossible to intubate them. In such situations, this surgical cricothyroidotomy is a life-saving procedure which can be done in few minutes. Okay, so your goals of securing the airway is to maintain adequate oxygenation and ventilation. This should go on simultaneously with cervical spine protection. So this is how you will manually stabilize the spine when you have removed the cervical collar and you're doing any procedure, for example, examining the neck or preparing the patient for intubation. So stabilize the head and neck with your forearm. Keep your fingers at the base of the neck, below the shoulders, and avoid any flexion, extension, or the lateral movement of the neck. It's very important, because the neck movements can worsen cord injuries and it may cause permanent neurological damage. Once your airway is taken care of, you will try to manage breathing and ventilation. That is, look for injuries that, like major injuries, which are an immediate threat to life. So these are tension pneumothorax, open pneumothorax, massive hemothorax, a flail chest with pulmonary contusion, and cardiac tamponade. So these are the injuries which can cause death within seconds and which need to be recognized. Cannot afford to miss them in the primary survey. So tension pneumothorax, what is it? So you know, pneumothorax is accumulation of air in the pleural space. Tension pneumothorax happens when there is a flappal mechanism. There is injury to the lung. There is a flappal mechanism, that is, air keeps on escaping during inspiration, and it causes the collapse of the lung. It pushes the mediastinum to the opposite side, compresses the opposite lung. So ventilation is severely compromised. At the same time, it compresses on the heart, the great vessels, decreases the venous return, and causes the fall in blood pressure. Sure. It is a clinical diagnosis, has to be managed within seconds. Otherwise, the patient can have cardiac arrest. Do not wait for a radiological confirmation. So what are the signs of tension pneumothorax? The patient can have breathlessness, chest pain, air hunger, tachycardia, tachypnea. There will be elevation of the hemithorax. There will be no breath movement or movement of the chest. There will be no breath sounds. It can be hyperresonant. It will be hyperresonant auscultation. The trachea will be deviated to the opposite side. Once you have diagnosed it, the treatment is insert a large bore cannula in the fifth intercostal space, slightly anterior to the mid-axillary line. So this will relieve the pressure in the pleural cavity, and it will convert the tension pneumothorax to a simple pneumothorax. Sometimes this may not be possible. A needle may not help to relieve that pressure. Whatever the things, the next immediate step should be to put an intercostal drain. So always keep an ICD set ready. Patient can have pneumo or hemo. Keep an ICD set ready so that quick insertion of an ICD can be done. This is open pneumothorax. Basically, what it means is the patient has injury causing an opening in the chest wall, which allows air to be entrained into the pleural cavity from exteriorly. So immediately at this side, whenever you see what you can do it, place a sterile cover over it, which is sealed at 3 sides. So this converts it into a flutter valve mechanism that during inspiration air escapes, and during expiration air will not be allowed to be entrained from externally. So this will, this is just a temporary measure, and at the same time you should quickly go ahead to put in ICD at a site adjacent to it, not at that injury site, at a clean site adjacent to it on the hemithorax. So you should go ahead and quickly put the ICD. Always remember to tape it on 3 sides and keep one side open. If you do it all 4 sides, then you'll be converting an open pneumothorax to a tension pneumothorax. This is a massive hemothorax. So hemothorax is accumulation of blood in the pleural cavity. And massive hemothorax is when there is accumulation of 1500 ml or more of blood in the pleural cavity. So once this hemothorax can be diagnosed clinically as well, you can do an X-ray. It may not be as immediately life-threatening as your tension pneumothorax. So hemothorax will present as difficulty in breathing, absent breath sounds on the side of hemothorax. Patient may be having hypotension because he is losing blood there. So we need to go ahead and quickly put an ICD. And after putting the ICD, if you see there is a return of 1500 ml of more of blood, or there is an ongoing blood loss of 200 ml or more, or if the patient is having continued need for blood products and is having hypertension, then the patient may need to go for urgent thoracotomy. So this is important. Once the ICD is placed and blood is coming out, you need to watch, keep a watch on how much blood is being drained. Cardiac tamponade. So basically this means there is accumulation of blood in the pericardial cavity. It compresses the heart and impairs the cardiac filling as well as the contractility. So this is diagnosed by a fast scan. We'll come to later on, we'll see what is a fast scan. So once a cardiac tamponade is diagnosed, it will present with signs such as respiratory distress, hypotension, muffled heart sounds, and once you've diagnosed it, go ahead and inform a surgeon. He may need an emergency thoracotomy, or it may be possible to drain it by ultrasound guided pericardiocentesis, whichever is faster, do it. Often if the bleeding source needs to be controlled, you may need an emergency thoracotomy or stenotomy. That's why it's very important in trauma situations to notify a cardiovascular thoracic surgeon. Next comes circulation and bleeding control. Hemorrhage is the commonest cause of death in polytrauma patients. And if the patient is hypotension, most often the cause is blood loss hemorrhage. So whenever you get the patient along with airway and breathing assessment, assess for the vital parameters, pulse, blood pressure. See for the level of consciousness, skin color, and urine output. It tells you about the blood flow and organ perfusion. Very important to assess all of them and interpret them in terms of perfusion. Okay, so simultaneously when you're assessing, start putting IV cannulas, 2 large bore IV cannulas. This is a must. Just go. This is the first thing that you should do. Put IV cannula, draw blood samples at the same time, send it for whooping cross matching for hematological studies, and start IV fluid at the same time. You may do an ABT at this point of time and look for the acid levels and the lactate levels because they are markers of your organ perfusion. So when you are assessing the patient, you have started him on a fluid. At the same time, look for where is he losing blood from. Externally, if you can see any bleeder, you can apply direct pressure with gauze pieces, or you may use a tourniquet. If it's a small vessel on the limb which is spotting, you can use a forceps. Be careful with the forceps, you may injure the nerve. And in case of pelvic injuries, it is very important to place the pelvic binder. So the pelvic binder, while maintaining the alignment of the pelvic bones, prevents the distraction of the veins, and it may slow down the bleeding from the pelvic venous plexus or from the injuries. So once the patient comes with signs of injury to the pelvis, there is you obviously have seen a bony distraction or hematoma, and that's it. Put the pelvic binder, and once placed, do not test again for injuries because your testing itself can cause further bleeding. If there is a fracture, it may need to be splinting. Splinting is important because by maintaining the alignment and preventing the motion of the fractured limb, it prevents pain. At the same time, it stabilizes the blood vessels and the bleeders. It may help to reduce the bleeding. And even if these measures are not helping, you may need to rush the patient for urgent surgical management of the bleeding. Shock. It's very important to recognize the presence of shock. And most common cause in trauma patients is hemorrhage. You may not be having hypertension, obvious hypertension. He may be compensating for it by tachycardia. So always be cautious, and any injured patient who is cool to touch and tachycardic, consider him to be in shock until proven otherwise. Or externally, if it's not obvious, but you feel he's in shock clinically, by assessment, try to keep looking where he is bleeding from. The potential sites could be the chest, abdomen, pelvis, retroperitoneum, extremities. So other than hemorrhage, sometimes these patients can be in shock because of other causes. For example, because of blunt injury to the heart, or because of MI, he can be in cardiogenic shock. If there is cardiac tamponade or tension pneumothorax, it's the cause for an obstructive shock. Neurogenic shock can be there when the patient has injury to higher cervical spine, causing spinal cord injury. Or he can be in septic shock. An elderly patient, he may already be having some infection ongoing at the time. If he meets with an injury, then he will already be in septic shock. So this is the classification of hemorrhagic shock. This is based upon the percentage of blood volume that is lost. So class 1 is less than 15% of blood volume lost. Class 2 is 15 to 30%. 3, 31 to 40%, and severe hemorrhages when more than 40% of blood volume is lost. So this you can judge by your clinical examination. Patient in hypertension and signs of low decreased organ perfusion like decreased urine output, altered sensorium, acidosis and ABG, definitely will have moderate to severe hemorrhage. These patients are the ones who need blood transfusion and at the same time rapid interventions to control the source of bleeding. No matter how much fluid and bloods we give, we will not put the patient to recovery unless we stop the source of bleeding. Based upon your resuscitation, we may have started the patient on fluids and bloods, and then we assess the patient to response. Your response is also the way the patient responds is an important indicator telling you whether his bleeding has been controlled and how he's progressing physiologically, whether he's stabilizing. So patient has minor bleeding, and with fluid response, he's stabilized. Rapid response, we know he's towards recovery and stabilization. Transient responses, when you have given a fluid bolus, he's shown improvement in the physiological parameters, but again, he's starting to develop hypotension or tachycardia or worsening sensory. So these patients, there is ongoing blood loss, and mostly he'll need more blood products and surgery, but there is some time. And the third group are the ones who don't respond. They are at risk of high mortality. They may need massive transfusion protocol to be activated, and these are the category of patients who need to be rushed immediately to the surgery. Hence, it is important to notify the surgeon as fast as possible. So resuscitation, how do you go about it? You start with crystalloids. If it's patient is a non-responder, severely hypertensive with obvious major injuries, you may be activating the massive transfusion protocol right away, asking for O negative blood. If you're starting with crystalloids, start with about 500 to 1 liter of bolus for an adults and 20 ml per kg for pediatric patients. Don't just keep giving crystalloid fluids. Limit it to 1 liter to 1.5 liter. It's important because the current concept, the resuscitation, is based on the principles of balanced resuscitation or hemostatic resuscitation. What it means is, what we have seen, studies have shown that excessive crystalloid administration is lethal. It can cause positive fluid balance. It increases transiently. It may increase the blood pressure and lead to dislodgement of the clot, further worsen the bleeding. It may cause coagulopathy, hypothermia. That is, it will worsen the lethal tide of trauma. So use optimally the crystalloids. Use blood products early and use plasma early. Use a higher ratio of blood to plasma, and have a low threshold to activate the massive transfusion protocol. This is what is called as hemostatic resuscitation. Next comes disability. Very important, that is to examine the patient for traumatic brain injury and spine injury. So assess the patient's level of consciousness. Use the Glasgow Coma Scale. Check for the pupillary size and reaction, and do a quick motor examination. Look for any lateralizing signs, and that will help to know whether there is any spinal cord injury. So the patients may have skull injuries or intracranial injuries. Intracranial injuries are the ones which may put the patient's life at risk and cause long-term morbidity. So it can be focal bleeding, like it can be an epidural hematoma, subdural hematoma, or intracerebral bleeding. Or the patient can have concussion, multiple contusions, or diffuse axonal injury. These injuries based upon these injuries, the patient will present with a particular clinical condition, and you can classify these injuries as minor, mild, moderate, and severe as per the Glasgow Coma Scale. That is, GCS of 13 to 15 is mild TBI, 9 to 12 is moderate TBI, and 3 to 8 is severe TBI. So the primary goal of management of traumatic brain injury is to prevent the secondary brain injury. The primary brain injury is the one which has occurred because of the impact of the trauma. We cannot reverse that, but we can prevent further damage by taking measures to prevent further organ damage. So it's important to maintain the blood pressure, maintain the volume status of the patient, ensure normal oxygenation, and maintain normal carbon dioxide levels. If the patient has low GCS or is comatose, then needs early intubation, secure the airway to provide oxygenation as well as to prevent any aspiration, and examine the patient for signs of raised intracranial pressure. If you're seeing signs of raised intracranial pressure, such as dilated pupils or pupillary asymmetry, worsening sensorium, signs of seizure, so you may need to give him quick medications. You may need to involve or inform the neurosurgeon again and rush the patient for a CT scan, or he may be needed to go to the OR immediately. He need some decompression. Last comes exposure and environmental control, which means a complete examination of the patient, completely undress the patient and assess him. At the same time, prevent hypothermia. Polytrauma patients have impaired temperature regulation and low perfusion. They are at high risk of hypothermia. Cover them with warm blankets as soon as you finish your examination, and make it a protocol to give them warm crystalloids, warmed at least to 39 degrees Celsius, and preferably use high flow fluid warmers. So this is a video of the log roll.
It takes 4 people to properly log roll a patient. This procedure keeps the patient's entire body in neutral alignment and minimizes any movement of the spine. It is helpful to cross hands at the patient's hip so that the team members at the patient's side will move together when rolling the patient. When signaled, roll the patient and remove the backboard. Now is a good time to evaluate the patient's back. When signaled by the person at the head, roll the patient to the supine position.
So this is a method to examine the back. Once we finish the primary survey, we may go on to the secondary survey. During the primary survey, we may be using these equipments, as these are known as the adjuncts to the primary survey, to help with monitoring and resuscitation. One of them important is sonography. Ultrasound is very important to diagnose the cause of hypotension. That is by doing a fast scan or any fast. That is, you assess the pleural cavities and the abdominal cavity at 4 sides to detect the presence of the blood. It's very important to have a working ultrasound and be ready, keep it on before the patient comes. Once your primary survey is complete, then begins the secondary survey. Secondary survey starts with a complete history and head-to-toe clinical examination and reassessment of all the vital signs. What I mean by completion of the primary survey is that immediate life-threatening injuries are taken care of and the patient is showing signs of stabilization. At this point of time, you start with secondary survey. So this is the ample mnemonic to take a complete history. And the secondary survey, that is complete physical examination beginning from the head to toe. That is starting from the scalp, examination of the head, maxillofacial structures, cervical spine and neck, the chest, the abdomen and pelvis, the perineum, rectum and vagina, the musculoskeletal system, and a neurological system. So to summarize, managing a polytrauma patient, it's important first to be prepared. Second, triage the patients, manage them as per the severity of the injuries. To begin with, primary survey, the most important management principle to stabilize the patient. You may need to transfer the patient sometimes if we don't have the advanced modalities to treat that patient. And after stabilizing comes the secondary survey and definite care of the patient. Thank you.